Well, welcome everybody. Today is July 22nd. We're back with another iteration of the Journal Chest Journal Club that we do live. I'm really excited to be here with with my co-moderator, Dr. Divya Patel. So my name is Viren. I'm one of the Palm Cred faculties here at Krause Hospital and SUNY Upstate Medical University in Syracuse. And Divya, do you want to introduce yourself?
Yes, thanks, Viren. I'm Divya Patel. I'm an associate professor at the University of Florida. My area of expertise is in sarcoidosis. And I'm very excited to be with all of you this afternoon to talk about this very interesting and I think a paper with a lot of clinical applicability.
And on that note, we also understand it's not afternoon for our content liaison, Dr. Pistelli. It's 10 p.m. where he is right now in Pisa. So Dr. Pistelli is, he's a pulmonologist with the cardiothoracic and vascular department at the university in Pisa, at the University Hospital. He is interested and studies actively lung function in the general population. We were having a very, very interesting conversation about how lung functions get affected and how we use different sort of reference points and reference values. So he works on derivation of those besides working in the smoking cessation practice at the university there. And then representing the list of authors for the study, which we will go into shortly, is Dr. Fortis. And Dr. Fortis is an associate professor at the University of Iowa, and similarly has research interests in COPD and PFT. If I may, he also just shared with us that he had started off with a critical care interest and then was heavily inspired by Dr. Pistelli. So this has already been a great start to this webinar. So with that, the study today that we will be discussing is about the use of slow vital capacity as opposed to forced vital capacity in patients who've smoked or are smoking, but their lung functions, the traditional lung functions, are normal or preserved, and how we can use SVC to identify obstructive lung disease in these patients. So smokers or ex-smokers, right, and preserved traditional lung function tests, so your FEV1 to FVC ratio, and then use of the FEV1/SVC ratio instead of the forced ratio. So with that, I want to go over the learning objectives, which I did, and then the disclosures. Dr. Fortis, if you would like to talk about briefly.
Yes, basically, I have no relevant disclosures with the topic.
Beautiful, and that's true also for Dr. Pistelli. So we'll get started. Some sort of housekeeping items. So if any of you guys have questions, please put them in the chat, and Divya will be monitoring the chat. She will bring them up with Dr. Pistelli and Dr. Fortis. We're planning to have a discussion about 30-35 minutes, following which we will have time for questions as well. So let's get started. So Dr. Fortis, I briefly did talk about what slow vital capacity is, but could you tell us a little bit more about what SVC is,
yes,
as opposed to the forced vital capacity?
I mean, so let me say first, vital capacity. What it is vital capacity? Vital capacity is the difference between total lung capacity and residual volumes. In other words, what I say to my patients, how big is your breath? And so typically measure from with a forced vital capacity maneuver, the usual spirometry. So in the forced vital capacity maneuver, a patient breathes forcefully and fast in to a total lung capacity, and then immediately blows out forcefully and fast to the residual volume. So this is convenient because just one maneuver, and you can get FEV1 and you can get FEVC. And it's reproducible, widely used. However, the vital capacity can be measured in other ways. For example, can we measure like a slow expiratory vital capacity maneuver? A patient breathes in slowly to the total lung capacity and then breathes out slowly to the residual volume. Another way to do that is with an inspiratory vital capacity maneuver. From the residual volume, the patient can breathe in slowly the total lung capacity. Now, in theory, all of these measures, and that Dr. Pistelli, maybe for accuracy, maybe saying, no, that's not true. But I would say in theory, they should be all the same, but they're not. In reality, they're not. And why is that? Because when you do a force fast exhale maneuver, like the FEVC, you increase intrathoracic pressure. And when you increase intrathoracic pressure, you have, like, I would say, simplify that, extrinsic compression of the airways, particularly in the small airways. And you may have collapse of the small airways and obstruction of the small airways at the end of exhalation. You may have what we call a dynamic airway collapse. And then FEVC is truncated, is small. And the problem with that is because the FEVC is small, the ratio, the FEV1 FEVC ratio may be higher than supposed to be and maybe pseudo-normalized. And this pseudo-normalization can lead to patients underdiagnosis of obstructive lung disease. A patient that may have a small airway disease, that's everybody's talking about this day, about small airway disease. It's a silent zone that you may not be able to detect it with a regular, spirometry, may have a completely normal spirometry despite the small airway disease. So, so for that reason, maybe the slow vital capacity maneuver, it could be better because there's a more sensitive test. And I will bring, I will cite another study also published in CHEST a few months actually prior to our study, Saint Pierre study, and they included in their analysis data from their PFT that have patients that have a normal FEV1 FEVC ratio and normal total lung capacity, and they categorized patients on based on the FEV1 SVC ratio, and they found that those patients that have low, or maybe I wouldn't say patients, I would say individuals, those individuals with low FEV1 SVC, they have higher rate of obstructive lung disease diagnosis per physicians compared to those that they have normal FEV1 SVC ratio. So, and that's how, we said, we thought the same thing. Maybe, the individuals with normal spirometry by the current standards, FEV1, FEVC ratio, and normal FEV1, if they have abnormal FEV1 SVC ratio, maybe they have more obstructive lung disease. And now the question is, what is obstructive lung disease? Is there any gold standard? And we use some markers, like objective markers, like CAT scan findings, like emphysema, gas trapping, PRM, small airway disease, and I can tell you a little bit more about that. Exacerbations and progressions, to COPD. You're muted. Yeah.
That's perfect. I think we should segue into study design at this point. So the data that you analyzed is from the Spiromex, data.
Yes.
And so the data was collected for the Spiromex study prospectively.
That's correct.
And as part of that, you already had these values and some of the endpoint or outcomes already collected, and you retrospectively sought to study it. So tell us, what all were the major sort of baseline characteristics you looked at the major ones, and then what were your outcomes? What were you hoping to find out about these patients?
And let me, Dr. Pistelli, I thought that you wanted to say something.
Yes, perhaps it should be underlined some other feature of the FEV1 SVC ratio. In particular, this ratio is also recommended by the current guidelines for the interpretation of lung function test. I refer to the ERS ATS guidelines of the 2005. The SVC, you have said that may have a larger value than FVC due to the lack of dynamic compression during a slow expiration. And thus, using this parameter at the denominator may facilitate to detect a reduced ratio. The guidelines suggest to use the largest lung volume which is possible to displace from the lungs during a pulmonary function test. But indeed, the guidelines does not recommend FVC or SVC, but the larger volume. This is a specification. Okay.
It's a good point, actually. Specifically, if I'm not wrong, the guidelines specifically say try to get a 10-second exhalation, right? Which is interesting, right? Because they do go to that specific. They don't talk about the force maybe in that much detail. So great. I was going to highlight that too. So thank you, Dr. Pistelli. All right, Dr. Fortis. So tell us about the study.
So let me tell you first about the Spyromics. So Spyromics, it's, as you said, prospective collected data, included current or former smokers with at least 20 pack years, so high-risk population. And it has 4 strata. Basically, the stratum number 1 is those that they have normal, they have like a post-FEV1 percent predicted above 80% and a post-FEV1 FEVC above 0.7. And the rest of the strata are those that have like COPD. So we focus only on those that have we analyze only those that have like normal spirometry, post-FEV1 percent predicted above 80% and post-FEV1 FVC above 0.7. And then what we did is we categorized the patients on 2 groups. Those that they have, and then you can see in the table 1, so the post-bronchodilator FEV1 SVC below 0.7, and those that have post-bronchodilator FEV1 SVC above 0.7. Now, I know that a lot of people that argue that we use, first of all, we use post-bronchodilator because the current GOLD guidelines, they use a post-bronchodilator for COPD, and that's what they used in Spyromics to define what strata they are. So we wanted to be consistent. So any analysis we did is either we did with post for all the analysis or pre all the analysis or lower limits of all the analysis. And so for the first analysis, we used 0.7, but also in the sensitivity analysis paper, we also replicated the same analysis with the lower limit of normals. Anyway, so back to that. So we took, again, smokers, current or former smokers with normal spirometric by the current standards, and then we categorized in the based on the post-FEV1 SVC. And we find that, as you can see, there's 120 patients from total 154 patients. They have low post-bronchodilator FEV1 SVC. And from the table 1 is the characteristic. I want to emphasize that the individuals with low FEV1 SVC, they were older. Age was like 65 versus 59. They have more accumulated smoking history. So the pack year smoker was like 50 versus 40. And they have also, worse lung function. For example, like the pre-bronchodilator FEV1 percent predicted was 89% in the individuals with low FEV1 SVC ratio, as opposed to 94% with those with normal ratio. The same, similar with post-bronchodilator. And the other thing you can see is like there is more evidence of obstructive lung disease in the CT features. Emphysema, for example, is like 2.3%. In the group with a low FEV1 SVC ratio versus 1.5, gastritis was 12% versus 7.5, and small airway disease was like 12% versus 8%. Now, just a clarification: the emphysema is it's a radiographical in CT. So the patient took a inspiratory maximum inhalation at the total lung capacity. They got a CAT scan and they measured hypoattenuation on that. And then the gas trapping is the hypoattenuation in the residual volume CAT scan. The PRM, parametric response mapping, is like a fancy technique that can measure the non-emphysematous gas trapping due to small airway disease. So basically takes match the emphysema and the gas trapping that gets in the inspiratory and the expiratory scan, and then with a complicated algorithm, find out what's the small airway disease percentage. So that's for yes.
Perfect.
Yes.
So, yeah, Dr. Pizzali, go ahead.
Yes, I would comment on this association between, which has been found between age and SVC. Indeed, it should be underlined that also in normal subject, it is possible to found a discrepancy between SVC and VC, which increase with aging. So this is an expected association. And the other fact that it is associated SVC associated with sign of emphysema and gas trapping underline the fact that this index indeed may reflect the first impairment in the natural history of the COPD, because the obstructed subject indeed may produce a larger SVC with respect to an FVC for the dynamic compression of the airways, which happens when it is performed the forced expiratory maneuver.
Yeah. Thank you. And talking about the impact of age on your different vital capacities and eventually ratios, let's go right into it. So to summarize, you have a data set. You take people who of X and current smokers but heavy total smoking.
That's correct.
You take the ones where their ratios are currently normal.
That's correct.
FEV1 to FVC. So technically they would have been normal people.
Yes.
Normal, you take that, and in them you do the FEV1 to SVC ratio. And you create two groups. One group has less than 0.7, one group has more than 0.7. So by this criteria now, one group already has COPD and the other probably doesn't have, or you're thinking that they probably do. Or
yeah, I wouldn't use we never use the term COPD for that.
Obstructive lung disease, sorry.
Obstructive lung disease. And as you said, we don't know what is obstructive lung disease. What's the gold standard? So, and then we are going to show you. The thing is to link it with outcomes and objective adenoid.
And tell us about the outcomes.
Okay, and why did you choose the cutoff 0.70?
So there is some, because the gold guidelines use 0.7. I'm not going to tell you my preference, to be honest, but I know that maybe that's not correct. Now there is one also problem with using a lower limit of normals, which we are thinking to use it. The problem with the lower limits of normals, if we use FEV1 SVC, there is no reference values, and you pointed out actually even in your editorial. There is no reference values. The same thing actually a lot of people are doing. There is no reference values for post FEV1 FEVC. I mean, in most of the population, at least in NHINES, we don't. I mean, I don't think anybody created. Maybe we have post bronchodilator somewhere, and probably somebody has to do that at some point. But we have only pre-bronchodilators reference value, but for FEV1 FEVC. And for that reason, we didn't want to use, initially as in the main analysis, we didn't use the lower limit of normal. So we went to 0.7, which it's kind of arbitrary anyway, but that's what we chose that. And then, so again, I will repeat. So in the main analysis, you said we used post bronchodilator and 0.7. Even to say which patient that will be included in the studies, even for which patient that will be categorized in these FEV1 SVC groups. In the sensitivity analysis, we use pre-bronchodilator for both how you defined the patient that will be included in the analysis, plus to categorize the patient. The same thing with the low limit of normal.
I agree with your decision. In fact, reference values for FEV1 SVC ratio are available, for example, in Europe for the ECCS reference equation, but you have studied an American population, so it would be wrong to use not population-specific reference values.
That's good. Thank you.
So we've established the reference. I was gonna ask you about that in follow-up. So we'll do that later. So now in this group where what was the associations in the group where the ratio of this FEV1 to slow vital capacity was less than 0.7, where basically we're thinking might be obstruction or is obstruction or...
Yeah. So the first thing we did is first we did a parsimonials model, like the logistic regression model that you see here in the table 2, to show what are the most important predictors of the low FEV1 SVC. So what are the characteristics of low FEV1 SVC? So but with the parsimonious model, basically you say, take away any confounders. So then what we saw is that if you are older, if you have worse lung function and more emphysema, then is when you are more likely to have a low FEV1 SVC ratio. This does not say anything about the association of FEV1 SVC with outcome. Just say what are the predictors of the low FEV1 SVC, and that's the table 2. Then can we move to the yes? So this is let's say more of the juice of the our findings. So here we have linear regression models adjusted for demographics and smoking, and that they examine the association of a low FEV1 SVC with the following outcomes: emphysema, gas trapping, and small airway disease. And as you can see, the individuals with low FEV1 SVC ratio, they have higher emphysema, 0.45% more emphysema than those that have a normal FEV1 SVC ratio. They have higher gas trapping, 2.5%, and higher small airway disease, 2.8%. And now, I know that some people say, that doesn't sound that a lot. 1% emphysema, it's very, very significant, actually. And 0.5 for a baseline, and for that population that they have, it's significant. Even 1% change of emphysema, there has been studied that increase mortality. So it's a very significant.
So Dr. Pistelli, as I understand, we basically have now determined that in this population where the slow vital capacity ratio is less than 0.7, you have greater percentage of emphysema on imaging, 1. You have more gas trapping by the PRM method that you were describing. And then you also have higher small airway disease accordingly because of that parametric response. So tell us about then, you followed these patients out for how much time? What was the median follow-up time? Because that has been one of the strengths of the Respironics, the Respironics data set, right? So what was your average follow-up time?
So first of all, I'll tell you, just to clarify, this is spirometry at baseline, and this is CAT scan at the baseline. And then we have like a follow-up. So typical, the patients have they have a baseline visit, and then they have like 3 follow-up visits. And now we have like more spirometrics, there will be more visits, but they have 3 annual follow-up visits. So I think the follow-up average time was like 1,500 days or something like that. So like three
So
years.
good solid 4 years
Yeah,
of median follow-up data. Great. So that is very important, right, in the scheme of any chronic disease. So Dr. Pistelli, maybe I'll direct this at you to start with. So it would make sense, I suppose, to study, right? Do these people who already have a compromised ratio, do they progress to 1, frank disease by traditional metrics? 2, do they start clinically expressing? And 3, do they then start also having problems such as exacerbations, right? So if you had to do the study or you had to design the study from follow-up standpoint, what would you look at?
So this data came from a study which has a retrospective design. However, it's a solid result, I think, to have observed the possibility to detect the progression toward COPD in patients, smokers, or ex-smokers, which have at baseline no airway obstruction as defined by the GOLD criterion. So this is a consistent, a solid result of the use of SVC instead of FVC.
So Dr. Fortis, walk us through what did you find on your follow-up?
Yes. So, since you have like figure 1, I can tell you about the figure 1 first. So, one is, as we said, we follow the serial spirometry, annual spirometry every year, and we examine what percent of the patients, how many patients they have like a COPD by the classic standard criteria, post FEV1, FVC below 0.7. And we did that also actually for the low limit of normal and the pre-bronchodilator, the same results. And then as you can see here, this is like an interval sensor analysis, kind of like the same thing as a typical Kaplan-Meier curve. It shows a COPD-free survival, and you can see the group that they have normal post-FEV1 SVC ratio, there is less chance to develop, COPD in the future. And we're talking about significant. We're talking about like what's like 40%. I think the actual numbers like something like 40% difference. So it's a big difference. And then if you go back to the previous slide, so this is the adjusted analysis for the interval sensor regression analysis, and you can see the hazard ratio for the progression to COPD is like 3.9. It's pretty significant. It is not talking just we have a large number sample size and we just find a significant difference. The other thing we did is because some of my co-authors thought, some of the patients, they may have COPD that may bounce back to the normal spirometry, or maybe go to this preserved ratio impaired spirometry, which is abnormal spirometry with abnormal FEV1 or FEVC. And that's, the current guidelines that say, you have to do more than one spirometer anyway. So we examine also the persistence of COPD. So somebody that has COPD and then persists in the follow-up spirometers, and we find the same results. Very significant association between the low FEV1 SVC and progression to persistent COPD.
Yes,
what were your thoughts on Dr. Pistelli, sorry, go ahead.
Yes, because it needs to be always underlined that the obstruction, the COPD, needs to be persistent, chronic, and not only one measure may be considered to diagnose obstruction. But there need more than one observation over time, and the study highlights this aspect, as the Dr. Fortis has pointed out.
Exactly, and the guidelines, like you both mentioned, make a point of it. So here's a question. I think the natural curiosity would be how many of the people in these two groups were still smoking, right? Because you did have ex and current smokers. So did you factor in for things like that? Because if, there's a difference in current smokers in the two groups, could that have caused this?
Yeah, so, can you go in table 1 again? I can show you, and then I can tell you. So here, for example, you can see the current smoking is actually the this one that says like at the baseline if the patient they were current smoker, and then you can see that less patient they were current smoking is the post-bronchodilator and the low post-bronchodilator FEV1 SVC group. Okay, which maybe sounds, I don't know, maybe counterintuitive. It doesn't sound counterintuitive to me. It's pretty common. I have seen that in many studies. So typically these patients, they have low FEV1 SVC. They probably have more symptoms. Even you cannot see that with the analysis that we have in the MMRC score and the CAT score, but they have usually more symptoms, and even will not be able to pick it up. And then for that reason, they don't smoke. Now, so for an analysis, we adjusted for current smoking status at the baseline and pack years. We don't have a good way to do to figure out, how much did they smoke between the visits and things like that. So we asked the patients actually in the spiromics, if they smoke, in the follow-up visits, but it's very difficult to introduce in the analysis. We have done some I think stratifications, but we cannot introduce the smoking status, like the smoking status during the follow-up study in the analysis.
And that's fair, but you did, I believe, factor for that, which is helpful. So
yes, we did factor, and then we factored for pack per years. And actually, to be honest, if it was, it will be for the fact that there's less current smokers with the post FEV1 SVC. That would be that our approach was even more conservative, let's say.
Yeah.
Okay. However, the pack years were higher in the group with a post-bronchodilator FEV1 SVC below 0.7.
Yeah.
So Dr. Pistelli, so sounds like in terms of the populations, they were balanced. Sounds like despite factoring in for confounders or variables that can have impact, there is progression in these people who currently are technically normal. So I think the question that I have for you is, keeping all of these data in mind, what would you tell a clinician like me? So I'm broadly an ICU guy. Like I said, I'm a pleural disease guy. I'm an area management guy, but I do my COPD clinic and I love my COPD patients. So if I was to ask Dr. Pistelli, I love this. This makes complete sense to me. How do I use this data thoughtfully?
I think we have to keep in mind the limitation of the data set, because this is not a general population sample, but are a selected sample of subject over 40 years of age. And so generalization must be done with some caution. I think that the basic message from this study is the key point of using the slow vital capacity at the denominator for the definition of the airway obstruction index. And it is to be considered that in the clinical routine, it is simple to perform two different two different tests, the forced expiration and the slow expiration. It takes, I think, very few minutes. This is, for example, the routine at our department. And so the physician should be start to take into account both the ratios, the FEV1 SVC ratio and the FEV1 and FVC ratio when interpreting the spirometry of specifically of smoking patients.
And Dr. Fortis,
can I add on something on that? As particularly, and we didn't emphasize that. And Dr. Patel has done a lot of research in that subject. When you have like obese individuals with increasing BMI, that can make things worse. And you can have a small airway disease or like a mild early, whatever you want to to call it, with a high BMI can mask easily obstructive lung disease. In that particular population, also I would definitely think twice, let's say, that to use a slow vital capacity if that's possible.
Okay, so populations where other factors such as potentially extra cutaneous, sort of restrictive diseases can hide the obstruction. Potentially use it for diagnosis if you feel that FVC might not be revealing adequately, I suppose. And then what about, when I was reading, and you can correct my interpretation of this, is that I feel like this might be useful for talking to current smokers who you're trying to, get them to quit smoking, because as a clinician, I run into that challenge, right? I talk to my relatively younger smokers and they're like, well, right now my lung function tests are fine. So maybe explaining to them that, hey, they are fine, but let's check this. And if it's low, you're already at risk of developing lung disease. So maybe it could be a motivational factor. Do you think that's a potential application or no?
Very, very, I don't know that question for me, but that's a very good point. So first of all, as far as, it's debatable, but most of, I would say, colleagues in investigators would say, we don't know for sure if they have an agent that can change the natural history of COPD. Okay. Now we can argue maybe a little bit wrong. Anyway, bottom line is that the most important is to quit smoking. And we know there is studies, I don't think there is a lot, but there is studies that if the patient knows that they have abnormal lung function or the worse lung function they have, they're more likely to quit smoking. So that's a very good point, as you mentioned. So if the patient knows they have abnormal lung function based on the FEV1 SVC ratio, they're more likely to quit. The other thing we are thinking ahead, and I think a lot of investigators are looking at that, because the pharmacotherapy, maybe when we introduce pharmacotherapy in COPD, maybe it's too late sometimes. Maybe we have to find patients with small airway disease that they have normal spirometry based on the FEV1 FVC ratio to start a pharmacotherapy at the early stages, and maybe that will be beneficial. So two things they can do. The FEV1 SVC ratio can help us to identify and early obstructive lung disease and motivate the patients to quit smoking, but maybe help the research community to identify a target group for future pharmacotherapy trials.
Yeah, no, this is a really great and useful discussion. I want to start out by going through the questions that the audience members have, because I think there's some nice questions here. And then, I'll save mine till the end. So the first question that an audience member asked is, could you expand more on, a little bit more on, how do you know that these changes, that these differences you're noticing between the groups are related to smoking rather than just age-related changes like senile obstructive lung disease, like lung function declining with time? They were hoping to get more discussion about that.
Yeah, so we adjusted for age. That's one thing we did, and we adjusted for a smoking status and back years. Now, as we said, it's always problematic. If we don't know what happened from the baseline that we do the measurements and when they develop COPD. I mean, we have data, but we cannot really say, what's, let's say, the smoking exposure during the program. So that's actually a limitation, but I think that's every study is limited in this sort. So, but we adjusted for age and we adjusted for smoking status. That's, I would say.
Yeah. Another question.
I don't know. No, I think Dr. Pistelli wanted to.
Oh, go ahead, Dr. Pistelli.
I agree with your response. Exactly.
So, Dr. Fortis, this is a question for you. One of the attendees asked if you guys did any subgroup analysis to see just effects specific in the asthma population versus the COPD, like the emphysema type COPD population.
Yeah. So, to be honest, I don't remember if we ever did it. I don't think we published that, but there was no difference at the baseline. Now, echo, it's actually something that I'm really, interested. It's my another subject. I'm very interested in that. And myself, I have even for the diagnosis of asthma. This is like a self-diagnosis of asthma and the diagnosis of echo in general. We don't have a good diagnosis. We don't have a good criteria for how to diagnose echo. A lot of people use the bronchodilator response, which is wrong because that's my opinion, at least. The bronchodilator response cannot distinguish between COPD and asthma COPD overlap. It's very common. We have some proposal, or we have some, we have published another paper about that. But anyway, bottom line is that no, we don't. I don't know if we conducted that analysis, but there was no difference in the asthma, self-reported asthma baseline. But it's also another topic that's very controversial. Let's say the asthma COPD. How do you diagnose? So how we can say what is asthma COPD overlap?
Yeah.
I don't remember, but if you go to table 1, there was a difference in the prevalence of asthmatic patients between the group with high or low FEV1 SVC ratio, if I remember. Can you go to the table 1?
There you go.
No, it was like it was 4.6 to 6.8.
Okay, asthma 107.
Yeah.
And 19. Okay.
Yeah, it's about the same.
Okay.
Okay, so another question that an audience member asked is, so the goal criteria is known to underdiagnose COPD in young people, but in this study where, there was in this study, the older age, seemed to have more obstructive lung disease and not younger ones smoking. So I guess they're asking, are you still seeing the underdiagnosis with FEV1 over FVC that you get using the goal criteria with FEV1 over FVC?
So if we use the lower limit of normal, is that the question? If we use the lower limit of normal, then you have the same findings, similar findings.
Yeah, I think you mentioned that. I think what they're trying to say is, the issues that you have with underdiagnosis in the younger population and overdiagnosis in the older population using GOLD with FEV1 over FVC, would you get the same with FEV1 over SVC? I think that's what they're trying to ask.
Oh, I'm pretty sure about that. So the ratio goes down. Every ratio, either FEV1 FVC or FEV1 SVC goes down with age. Mm-hmm. And if you use the 0.7, for probably an 85-year-old, maybe that's okay. But 0.7 for me, that I'm 40-year-old, so it's actually pretty low. Yeah, so it should be the same thing. And I don't know if Dr. Pistelli agrees with that.
The ideal situation would be having the reference for SVC, FEV1 SVC ratio. But when you have used the NANE's reference values, you have obtained a similar result with the fixed ratios 0.7. So in this population, which are subject with 40 years of age, we can expect to have an over estimation of airways obstruction.
All right. And the last question from the audience is a little bit provocative, and I'm curious to see what you guys think. Should FVC be removed as a measure and I guess replaced with SVC? And does it still have value in light of the data that you're showing? I think this is the question that we all have.
I mean, first of all, I don't know if I will remove it. I mean, we have to be, I mean, a little bit, let's say, more, let's say, cautious. But we do really, believe that's probably a better measurement. That's the reason we did the study. Now, still we have to overcome few obstacles, at least in the States. So we need to have FEV1 SVC reference values. And ideally, we should have like a study, but I don't think it ever happened. A very long study, and you compare the one ratio versus to the other in all the populations, and then I don't know, like make an AUC curve with using an FEV1 FVC ratio and the FEV1 SVC ratio with a study that's like 30 year long or something like that, which I don't know if we never have, but that will be a way to say, okay, definitely and that will tell us, okay, if the FEV1 SVC is associated with worse outcome, maybe this is where we should go. We should use the FEV1 SVC.
And sometimes this is the problem with adopted, I feel like, measures, is because remember all the studies in COPD and obstructive lung disease are done with your current sort of, measurements. So now we won't know then what to do with it. So I hear you, but it sounds like there's a niche application which we can use it, right? We don't have to get that hung up on guidelines necessarily. We can use multiple data points. So I'm really excited. I'm actually hoping to use it a little bit more about in the patients we discussed. So
I can add like few, let's say, out of the box. For example, like there is another paper in chest, for example. And I don't remember, that was like a while ago. I think it was lung transplant patients, and they used the ratio SVC FVC ratio. I think we have cited or in the manuscript, and then they detect obstructive OB, bronchiolitis obliterans, from the lung transplant earlier than the reduction in the FEV1. So there is people that use it, and also we know that there is association with the SVC FVC difference and symptoms in COPD. So it is published before. You can use it. Maybe it's not in a large scale sample studies, but it is.
So Dr. Fortis and Pastelli, I have a question. After I read this paper, I actually called our PFT lab director and asked, do we do this test, and like, what would it take to add it? So I was told we don't do it here at our institution, but I'm curious, like how much time commitment to get SVC data? Like, does it add a lot of to the time of the respiratory techs that are getting these studies? And in terms of cost to the patient, like, would there be a significant cost, or do you think that it should be doable relatively easily and with less resources?
Dr. Pistel, do you want to go first? I can tell you the US experience from my experience, and Dr. Pistel can say in the US. And actually, he already said that it's easy, but I will let Dr. Pistel to answer first, and then I can tell.
Excuse me, but I have not had. Can you repeat, because I have lost the audio?
Sure, no problem. What I was saying is that at my institution, we don't do the SVC study. So if I want to convince, the director of our PFT lab to get this test, like, what could I say? Usually, what their main concerns are tests that take too much time or too many resources or cost too much money. So how could I convince them that we should do this test?
The basic information is that if we perform the SVC maneuver and then we can discover much more obstructed subject, we can do a benefit for this patient. I think that in terms of cost, it is not so important performing the slow vital capacity maneuver in addition to the FVC maneuver during a routine session of spirometry.
Mm-hmm.
I will add on that so SVC is typically, I don't know any PFT lab in the States that is not part outside of the plethysmography. So typically, if you do SVC, you need to have a plethysmography.
Mm-hmm.
But I don't think that's necessary. And you don't have to do it. Why you have to do plethysmography? Number one. Second, there is some centers that do, for example, like, I don't know if I should, but I don't know if I should name specifically, but I can, in University of Minnesota, they do like plethysmography for every patient in the spirometry. In Mayo Clinic has published a lot of studies using, I don't remember if they use SVC, but they do plethysmography to everybody. So, yes, I know that, it takes more time, but it can be done. And the second thing is, we don't have necessarily to tie it together with the plethysmography. Maybe we can just do a slow vital capacity maneuver by itself.
Mm-hmm.
And
so
usually in the clinical routine, usually with 2-3 maneuvers, you obtain a reproducible test.
Okay.
So
Okay.
in very few minutes.
Okay, that's wonderful. So awesome. I think that's all the questions we have from the audience. Viren, anything else?
No, I think this was good. I think we've talked about the study, the implementation, and the fact that this is actually easily doable with current resources, which is what made me most excited about this article, because I think that's the challenge. Most of the times with research, can we get this? Do we have the resources, the funding? I feel like this is a pure clinical application. So I'm super excited, Dr. Fortis. Thank you, Dr. Pastelli. Thank you so much. And thank you for inspiring Dr. Fortis. Yes. So we can have the good science that you're both producing, okay? And have a good time. We have 5 minutes return to the day, which is always a great thing. And keep contributing to the journal. And we will see everybody next month, okay? Bye-bye.
Thank you
so much.
Thank you. Bye.